just thank the faculty, Dr. Adrian Koh and Dr. Rupesh for inviting me to share with you my experiences. But first of all, in the morning, and to begin the course with, we have some very basic principles to actually lay the stage for your subsequent lectures for the three days in the course. So first of all, we'll do the symptoms and signs, but I'll aim to make this interactive, okay, so that that would maximize all our learning experiences, both for you and myself, all right? So now, can anyone just tell me what you're seeing here in the slides? So these are anterior segment photos. Just feel free to volunteer your answers. KPs, right. So are you able to describe the kind of keratic precipitates that we see here? Okay, maybe the first slide. How would you describe it, or how might you expect your junior to describe it to you? Because these are some basic principles that are always basically laid out for my residents. So when they present cases to me, they have to actually describe the keratic precipitates, just like how our records, okay, how you document your records, how you document your clinical signs in your notes, because this is going to help guide how you do your workup or what you plan to do in terms of tests. Okay, so first of all, what do we see here? Actually, can we just pass the mic down? You think we can do that? Okay, so that we can make it interactive, okay? So we just go from the front and then we go across, all right? So gentleman first. Right, how would you describe?
Thank you for the first picture. I see small KPs.
Yes.
For the second one, I see only corneal edema, and the third picture shows large or nodular KPs.
Okay. Is there another name for this kind of KPs that you see? These large KPs? Do you know of any other names?
Nodular.
Nodular. Anything else? Martin fat KPs. Right, that's right. Do you know what KPs are? Would your friend like to tell us what keratic precipitates are? What do they represent? You see them in the corner. It's okay, you can just pass. It's okay, just pass if you're not sure. That's alright. Just pass the microphone. Do you know what keratic precipitates represent? None. So the aggregates of macrophages, epithelial cells, especially the mutton fat KPs. Okay, so when you see mutton fat KPs, or these nodular-like KPs, then you would have to think about certain specific causes, and therefore you tailor your investigations accordingly. Okay, can you see anything beyond the corneal edema here? Because indeed, this patient was referred to our cornea service for corneal edema. There's something else. Can you see anything else? Huh? Yeah, there are actually keratic precipitates behind this as well, okay, and they're mutton fat. Alright, okay, so you have to see beyond sometimes, what is really obvious as a clinical sign, because as uveitis specialists, we are actually tantamount to being detectives. We are out there to actually locate an etiology, although sometimes, many times actually, in fact, most of our workup just turns up negative. But there again, it always starts with your symptoms and signs, okay? That explains the importance of this morning's talk. And right, so how else would you describe the KPs up on top here? Small to medium size, yeah? And do you think these are fresh KPs? You find that they're slightly pigmented, okay, so they've been there for some time. So your fresh KPs or keratic precipitates are typically white, all right? And the older KPs tend to look a bit more crenated and more pigmented, okay? So that's how you distinguish between a fresh case of uveitis or a fresh recurrence versus basically one long-standing chronic anterior uveitis, for instance, all right? Okay, so we'll move on next. What do we see here? Whoever has the microphone. Would you like to volunteer?
This is a further photo with hypopion
Yes.
and posterior symmetry.
Yes. Okay. and probably a fibrin plaque there as well, alright? So what would you do next? Okay, so if this patient came to you with a intraocular pressure of 35, what would you do next? What do you think is the next logical step? What do you think is the cause of the raised intraocular pressure in this case?
Probably because of the clogging of your inflammatory cells in your meshwork, and of course pupillary block.
Okay, so how should we address the pupillary block?
You can try to give mydriatics and try to break the silicae,
What would you give in terms of mydriatics or topicals?
Yeah, topical mydriatics.
What would you give?
To try to break the posterior silicae to relieve the pupillary block.
Right. So in your center, what do you usually give?
We give atropine and phenylephrine
And
initially.
initially.
Atropine,
Okay.
phenylephrine. Of course, if you can control the intraocular pressure and try to do laser iridotomy.
Okay, so that's what I'm leading up to. The common mistake that most people make is to perform a peripheral iridotomy because they think this is actually primary pupillary block. Okay, but this is not. So once actually, if you have had sufficient experience with this kind of cases, you find that most of the times, okay, when you give mydriatics, basically phenylephrine, that's my preference, and tropicamide because they act synergistically, and phenylephrine, by phenylephrine I'm talking about 10% phenyl. Okay, so phenylephrine and tropicamide both work synergistically to help break away all this, this occlusal pupillae and help actually relieve the raised intraocular pressures. The mistake is to do a PI or peripheral iridotomy because these PIs will close up, number one. Number two, they will exaggerate or worsen the inflammation. And in fact, if you really need to move on to surgical management, it has to be a surgical iridectomy. Okay, so never do a laser PI, all right, because this actually worsens the whole inflammation that's going on in the eye. Sometimes it's never possible to break all this posterior synechiae just with drops alone, and therefore you have to consider surgical options like a surgical iridectomy. Okay, all right, and of course, what do you think are the etiologies? If you see these two signs, pass the slide on the microphone. So if this is a 27-year-old man, otherwise healthy, he comes to you.
Are we concerned about like a HLA-B27?
Okay, excellent. All right. Okay, so then thereafter, if you have a 74-year-old gentleman with the same clinical picture,
I think we should take a history without any effective etiologies for us.
very good, excellent. Okay, but it can still be a HLA, but still you have to think about infective causes. Okay, so you can now tell that with age, okay, the etiologies also differ. All right, so age makes a difference, right, and the background and systemic history as well. Okay, so we'll go on to the details later. Next slide. Okay, so this shows a fibrin plaque thing and posterior synechiae, how most of the posterior synechiae is broken away to actually just review a quadrant. Okay, I'll start down iris. Same thing here, just to show you that this is actually a secondary pupillary block. All right. Occlusal pupillage with 360 degrees posterior synechiae. And this shows you actually, basically this patient presented with 2 days history of redness, pain, photophobia, and right eye, and basically that's the process that the pupil got through within about an hour of receiving phenylephrine and tropicamide. Okay, so for my residents, I'll say that in freshly presenting cases, keep the patients in the clinic until you have actually witnessed the posterior synechiae breaking away. And from a pressure of actually about 36 or 40 at presentation, okay, an hour later, the pressure became 12, just with tropicamide and basically phenylephrine 10% alone. Okay, so this is your first step without any help from Dymox, no need for any topical antiglaucoma medications. Okay, so the first step, break the posterior synechiae. Now, can anyone, okay, next.
Excuse me.
Yes.
How many times you consider to give topical, how many times?
How many times?
Yes.
Usually I'll tell my residents to just check on the patient about half an hour later because it does take time for the drops to work. It's just like how we dilate patients in the clinic. You know, there's very variable onset of action, but typically about 10-15 minutes. Yeah, so you will have to just add on drops as necessary. But if you try 1 hour, 2 hours, it's still the same. I think the process time get, especially the chronic ones, they are not certainly going to break away. Yes, you said. No, they don't. No, just drops. Okay, so can anyone just describe the signs seen here? What's most obvious or what's most striking? I'm not giving any history, so.
So this is the anterior segment photograph of the patient's left eye.
Yes.
The eye is white, not injected.
Yeah.
I think the main pathology is in the iris at about 5 o'clock.
Okay.
It looks a little bit atrophic.
Okay.
I can't see, I would like to look whether there's any peripheral anterior sign K.
Okay.
But otherwise the cornea looks clear.
Excellent. So
you
what
check.
etiology are you thinking about now?
So I'm thinking of causes of iris atrophy, especially sectorial causes.
Okay, so what it is?
I mean, in the context of this case and the cause, I would be thinking of like infective causes, maybe hepatic, viral.
Hepatic, okay. So what kind of hepatic virus in particular?
Yeah, it's either HSV or PZV. I can't remember which one.
Okay, so sectorial atrophy is typically disasters, okay? So this
Thank you.
this patient was referred to me from Indonesia, Jakarta. She came presenting, basically the history. She's already partially treated. So again, in the history, it's important to establish, whether patients are on medications, what medications they're on. Many times they're on systemic and topicals as well. And so she presented actually back in Jakarta with a pressure of about 30 in the 30s. And during then, she had actually recurrent eye. So every time she stops topical steroids, the flare, it would actually just flare up. And so there was never actually there was never actually a complete resolution. Okay, so I'm going on to later with the SUN criterion. We're going to talk about chronicity and how we define acute, chronic, and recurrent episodes of uveitis later. So she's a recurrent anterior uveitis, okay, and basically it's zoster, okay, so that's what I'm treating her for, and therefore some patients with zosters and etiology, they might have to be maintained on a once a day or twice a day, that sweet spot, okay, once a day, twice a day, topical steroids. And so therefore, if you're treating patients or you're seeing patients with your consultants in the clinic, okay, and you notice that patients have been on once a day or twice a day topical steroids for years, please don't attempt to stop the topical steroids. It's there for a reason. Okay? Alright. So this is okay, shall we pass the mic on? Can we just move on with the description of the signs here? Can I help you alright? Because I'm not too sure how the resolution goes. It's optos. Can you see anything here?
It looks like a peripheral uveitis or vasculitis.
Yeah, okay, and some scarring here, right? Coral, retinal, atrophic changes as well. Okay, so these are signs suggesting peripheral. Alright, so what etiologies might you think of in this case?
Maybe it's from the vein type of vasculitis. So I'm thinking like maybe these can be a lot of reasons like the shape or even the shot.
The short, it's not very common here in Singapore. Yeah, more common in the Caucasian context. Basically, okay.
Uveitis, sarcoidosis.
Okay, very good attempt. Yeah, sarcoid does present like that, okay? So like the kind of wax dripping kind of signs, huh? So essentially, there's a whole list of signs. You have to actually be able to pick out whether this inflammation around the vessels, or what we call peripheral, around the veins, all right? Or arteritis, it is around the arteries, those who have been in ARN. And so basically, you have to distinguish, okay, which vessels are being affected, because that's going to help you in your differential diagnosis and hence your workup and management. All right? Okay. I'll go on to the list of causes later. And what do you see here? Just pass on the mic. What's
I
over
saw a
here?
lot of like fibrous
Yeah, okay.
fractions along the obliques and along the superior inferior
Around,
vascular
yeah.
arcade.
Okay, what else is happening here? So this is my patient actually with a sarcoid granuloma at the optic disc. Okay, so that is actually sarcoid granuloma, alright? And that's how she looked after treatment. Okay, and that's like after many months of treatment. Okay, so sarcoid granuloma here. She was being actually managed elsewhere for what was thought to be IH. Okay. Okay, and now something else. Very simple. What do you think it is? 50-year-old gentleman cannot sleep. He's very distressed. This group of patients are particularly distressed when they come to you. They're never smiling. They come to you the most miserable, in the most miserable state. What do you think?
I see as it is scleritis. Scleritis.
Scleritis, excellent. Okay, so you typically notice that when you see scleritis patients, when you come to your first presentation before they're being treated, they are the most upset patients because of the pain. Alright. So your history is also very important, and that's going to help you distinguish yourself by clinical signs, your episcleritis from your scleritis. Okay, alright. And so this is how he looked many months later after treatment. And what do you see here? You see some areas of uveal thinning, okay, over
Yes,
the previous
yes.
spot of scleritis. Alright. Okay, good. So symptoms and signs are important because that subsequently guides our workup. I shall not actually spend too much time on that because Dr. Chan will be delving into greater detail and sharing with you what to do specifically. But symptoms will give you the history, like in medical school, okay? And clinical examination will give you the signs, and that would all guide our investigations management. Okay, so the next question that basically, or rather the next direction that a good history and clinical examination will point you towards would be, what should you do for the patient? Okay, so I would say there is no such thing as a standard workup, okay, for uveitis, because it differs from patient to patient. It differs in terms of basically how the clinical signs present from time to time. So my typical approach to patients, because these patients tend to be with you for a long, long time, okay, and what I would initially tell patients at first presentation is that we might have to do some tests, but I wouldn't do all. But subsequently, years later, months later, if the clinical signs change and point me in a different direction, I might have to repeat some tests or do further tests as necessary. Okay, so there is no such thing as a standard workup. All right, it adds cost to your healthcare system. Okay, so again, management-wise, the key principle that I'd like you to take back with you from this first lecture will be first to distinguish between infective and non-infective causes. That should be actually the principle behind our approach to uveitis, because that's going to change our entire management, whether you give steroids or not. Okay, so the first principle would be to distinguish between infectious versus non-infectious etiologies. Okay? Now, the IUSG has laid down certain clinical classifications of uveitis. So if your approach can always be classified into, is this an infectious etiology, is this a non-infectious etiology, or is this a masquerade? I think you should be safe actually for your practice. Alright, because if you keep revisiting all these questions, because sometimes we are never quite sure, to be honest, what the primary cause is, or rather could it be non-infectious or infectious? Sometimes it's hard to distinguish between these two, or even a masquerade. Okay, but certainly when we are unsure, we have to watch the patients more closely, monitor them at closer intervals. All right. So this is something that actually one of my residents shared with me during one of our grand rounds in the hospital. and I'd like to share that with you. Okay, so this is Dr. Van Gelder from University of Washington Medical Clinic, and basically he shared something very pertinent to our approach in uveitis. Okay, so no such thing again, as I've said, as a standard workup in uveitis, and basically it's how you fish. Okay, so you start fishing with your history and your clinical examination. Okay, so bring a fishing rod when you look for uveitis, because you really have to fish for the possible causes. And if you cast your line, you have to reel it in, because basically, number one, if you do a lab test, please follow up on it. Don't leave it to your juniors or your colleagues to do it. Okay, and don't ever fish for things you don't know how to cook. So the common mistake, which I actually do agree with him here, is to send off an A&E. And many times you find that, actually I'll say 20-30% of time it comes back all positive, and you don't know what to do. So would you send them to a rheumatologist when you're systemically well otherwise? And the rheumatologist is just having a vigilant clinic just to evaluate your patient with positive A&E and nothing, no other clinical signs. It's a waste of patient's time as well, to be honest, okay? And basically, I would say for most of the times, A&A doesn't feature very highly in our list of workup, unless specific signs point to or symptoms like optic neuritis, etc., okay, concurrent with anterior uveitis or vasculitis, for that instance, might point you towards pursuing a cause, etiology such as SLE. Okay, all right. So now we go into the crux of history taking, which I would think many of you will be familiar with. Again, to emphasize why history taking is important, because number one, the age would suggest certain etiologies. Okay, the severity is important as well, because that would help you monitor the patient over time. Chronology, we'll go through that later. And pathology, okay, so as I've said earlier, whether it's granulomatous, non-granulomatous, anterior uveitis, that will also direct you in your workup. And basically, SUN has a certain criteria. Do you know what SUN is? Sorry. You know what it represents? So it's a standardized uveitis nomenclature. Okay, so because that's for, number one, clinical purposes, so that basically you and I speak the same language, all right, on the world stage. Okay, and also for research purposes as well, so that basically, you can pull the cases across all centers and you know that we're all talking about the same thing. Okay, so it's broken up into anatomical classification, and then you can talk about actually, the patterns, the etiology, and also laterality will help you decide whether you might just want to work up the patient, for systemic causes, especially if they present bilaterally, okay, in the first instance. Now, so this is the SUN work group, anatomical classification, tells you about anterior, intermediate, posterior uveitis, and how basically where the primary site of inflammation would be. So can someone share with me, how would your anterior uveitis patients, or how do your anterior uveitis patients present? Whoever has the mic next.
They will present like pain, photophobia, redness.
Excellent. Okay, so basically, these are the typical clinical signs that AAU patient might present with, but intermediate. Go on, it's fine. You're doing very well. Intermediate uveitis?
Intermediate, there may be cells flares in the as a symptom, but we have to dilate and we have to see within indentation, we have to see if there is any kind of snow banking or anything.
So what are the typical symptoms that patient would, or the history, in the history, what would you elicit? How would you know that that's intermediate uveitis? And not just a spillover into retrolental space, because you talk about cells. How would you distinguish in a clinical history that this sounds like intermediate uveitis?
History may be like multiple sclerosis or typically maybe classical.
Okay, but symptoms in a history-wise? So these patients typically tell you that they have they see floaters, right? Yeah, and then sometimes they might tell you a bit blurry vision. Okay, and if they have cystoid macular edema, then certainly blurring of vision would be one of the main symptoms as well. Okay, all right. So posterior uveitis as well. Typically, they can just present with blurred vision. All right, and similarly for panuveitis, everything from front to back. Okay. So again, ocular symptoms are important because they help direct you in terms of pinpointing where the anatomical localization of where the inflammation is. And again, it helps you in your workup, okay? Because when you think about intermediate uveitis, you have a whole set of etiologies that you're starting to chase, all right? Okay, so this is an entire list. You can find it in any standard textbooks. But basically, again, just to emphasize, how not distinguishing between non-granulomatous versus granulomatous uveitis does guide your treatment and your workup. Okay, and basically, whether it's unilateral or bilateral, it also does help, guide, again, your diagnosis, whether it's lens-induced versus something else that is more systemic. Okay. Again, posterior uveitis, pen uveitis, a whole lot of causes. And I cannot emphasize more that we have to distinguish between infective and non-infective causes at all times, okay, in our approach. Right? And as mentioned earlier, this is the entire list of retinal vasculitis. You can find it actually in standard textbooks again. Okay, so veins, be it veins, arteries, or both veins and arteries, being affected, and vasculitis, they help point you again to a possible cause and therefore your workup, okay, and not doing any standard workup out there. Okay, so this is the SUM proposed descriptor of uveitis based on onset, more importantly the duration and the cause. Okay, duration, usually the cut-off is set at 3 months, okay, and also for the cause, which they classify into acute, chronic, and recurrent. Okay, that's actually talking about whether there might be a relapse within 3 months. If it's less than 3 months, usually this patient is termed chronic, case of chronic anterior uveitis, for instance. All right. Now we've gone through that. Okay, a bit anterior, intermediate, posterior uveitis. Okay, they have their very specific symptoms. Sometimes it's not possible to distinguish between the three. But this should actually lay the grounds general guideline to point you to the anatomical primary site of inflammation. Okay, and also it's important to establish whether there were previous similar episodes. And again, if you're thinking about sympathetic ophthalmia, okay, you have to distinguish whether basically there was any history of ocular trauma surgery. So SO versus VKH, okay, or Revoke, Kayanagi Harada. And again, any systemic disease, if the patient already came to you telling you that he has long-standing history of back pain, okay, on treatment with rheumatologists for ankylosing spondylitis, then the first thing you think about in a red eye patient without any hypopia and fibrin is whether or not this is a HIV-27 related anterior uveitis. Okay, all right. And then the immune status as well will be important to establish, okay, because these patients have a higher tendency to, number one, they might actually be infective causes like CMV retinitis, if you think about that, okay, it's getting increasingly more common, TB in an immunocompromised state as well, and of course, secondary malignancies, okay, so like masquerade, okay. And family history and drug history is important because if they are on systemic immunosuppression for other reasons, then their signs might be different. Okay, so you're thinking, typically I would see this, and this, or fibrin or nodules, but this patient is presenting quite atypically. In fact, not as I would have expected, but that's also because their immune status is different. Okay, so that is important, therefore the drug history. And so, entire list of systemic causes. Again, you can find all this easily in textbooks, but it's good to just keep a year out, okay, to patients for any relevant past medical history. Examination, as we have discussed, or rather we have seen in the slides, is important basically most patients come to your clinic already with a visual acuity or best corrected visual acuity charted, okay? So what would be important would be to distinguish the type of chorotic precipitates, as I've shared earlier. Okay, the amount of anterior chamber cells, I will explain to you why it's important to quantify it at first presentation. Okay, any flare, fibrin, hypopia, but basically flare sometimes can just remain in cases of chronicity. Okay, they might not actually totally resolve, but your cells are very important signs of whether we are actually hitting the sweet spot in terms of treatment. Okay, and of course the iris. What do you look for in iris? So you saw a picture, right, just now? atrophy, the type of atrophies, nodules, alright, okay? So, nodules, posterior syndicate, atrophy, heterochromia, we hardly see it in Asians, this brown iridis. Okay, so it's less common in our local context, okay? And of course, your intraocular pressure. So aside from looking for signs, then your basically attention has to be drawn to intraocular pressure, because whether or not this intraocular pressure rise is associated with presentation. So if someone presents with anterior segment inflammation and raised intraocular pressures, then again, your etiologies are directed towards basically your hypertensive uveitis list of causes, right? As opposed to somebody who said, oh, I've been treated before with eye drops back at home, and 2-3 weeks later when I presented to my ophthalmologist, the pressure was okay at presentation, subsequently became elevated. Then what are you thinking about? A secondary ocular hypertension, isn't it? Okay, so then you think that it's steroid induced. Okay, all right, so it differs. Okay, so you want to establish whether it was raised or not at presentation, at first presentation in fact. Okay, so other signs of uveitis that you should actually chart. Okay, even significant negatives are very important, and that's what I always emphasize to my residents. Okay, vitreous cells and where relevant, okay, evidence of any snow banking, no evidence of chororetinitis, even all this has to be documented, no vasculitis, okay, and any, again, complications from the inflammation, like a cystoid macular edema, okay, or serious retinal detachment, right? So this is again an emphasis on the SUN criterion for grading scheme. Okay, so to say that a patient has improved with your treatment, you have to actually have a 2-grade improvement. Okay, so therefore your grading of cells is important. So it's a lot of numbers to remember, but since I was a junior resident, the one thing that I felt that was quite easy to remember is if it's 1+ cells, it's about 10, 2+, 20, 3+, about 30, anything 4+ will give you a hypopium. Okay, all right. So this is how you probably can easily remember, but this is actually just to emphasize that this is all measured with a 1x1 slip-in. Okay, all right. And then this is the grading for anterior chamber flare, whether or not the lens or iris details are well seen, and posterior pole details, again, used to distinguish between your 0 to 1 grading or mild to severe grading for vitreous haze. Okay. All right. So again, as I've said earlier on, to actually say that patient has improved activity, you have to have a 2-step decrease in the level of inflammation. Okay. So you might not be seeing the patient the next time around, but it's actually good to document the amount of cells, because the next time around when somebody else reviews the patient, your colleague, at least they could tell if the patient is responding. All right, okay? Okay, so just very quickly, some very, just few slides just to illustrate some clinical signs. Okay, so conjunctival injection, as you all have known by now, corrected precipitates. Okay, these are more obvious Martin fat KPs. All right, okay? And then non-granulomatous and granulomatous. And then your posterior syndicate, iris, okay, the iris atrophy, the type of iris atrophy, okay, and nodules, kidneys, pustukas, okay, and dilated iris vessels that you would sometimes see in certain uveitis, okay, and of course, anterior chamber angle, you have to look at the angle whether or not there's evidence of PAS. Why is it important? If you see tented PAS, what would you think about? Tented peripheral anterior syndicate. Sorry?
Tuberculosis.
Tuberculosis. Okay, it's less tented, typically sarcoid. Yeah, okay, but if you see PAS in cases of granulomatous uveitis, then yes, you have to think about TB, think about sarcoid. Okay, but if you see a tenting, then sometimes you have to think about the sarcoid, but certainly it's one of the thoughts. Okay, so there are some twins actually going along in uveitis. Okay, so when you think about one, you have to consider the other as well. So TB and sarcoid always goes along together, like SO and BKH, they're always hand in hand. Okay, so you have to distinguish between the two. Okay, all right, good, excellent. Okay, so the lens as well. You notice that most of the FHI patients come to you with a PSC cataract because they've had yawns and yawns of topical steroid treatment. All right, and again, as I've shared, okay, distinguishing the between the knowing the presenting intraocular pressures is important. Okay, and okay, so this just shares with you what we should look out for in terms of vitreous examination or posterior segment examination. Okay, then this shows past uveitis here, some snow banking. All right, it's a bit hazy because of all the vitreous cells. Okay, all right, and evidence of some choroiditis. Then again, all the entire list of causes will have to be considered. Vasculitis here. Okay, and retinitis. Okay. Right, then macular, you look for CMO, RP, pigment clumping, okay? And basically optic nerve, you look for, as I shared with you, infiltration. Yeah, you saw my patient with the sarcoid granuloma, the swelling, okay, as a result of the inflammation, or whether it's concurrent optic neuritis. Okay? So some learning points to end off with, that basically uveitis may exist as a clinical manifestation of an underlying systemic disease. So therefore, history is very important, okay? And sometimes, a meticulous clinical examination will help you guide and save patient actually save them actually money, in terms of how you can do a more directed workup, all right? Okay. So I hand over the stage to Dr. Anita Chan now to share with you the workup of patients in uveitis. Any questions you have for me? Yes. Sorry, I didn't get a finger size. Can you get a microscope and then so that I can hear you better? I just heard the cataract.
I mean, you come across patients who present late to you with a dense cataract that no view of fundus, but anteriorly you see some signs of old anterior effect like KPs or pigmented KPs or PS. So how you put your differential diagnosis? I mean, and your provisional diagnosis, whether it's an anterior or it's a pan uveitis, because you don't have signs of, don't have views of the posterior.
But you have the symptoms, right? So you first ask the patient at the beginning, when things happen, how did it all happen? What presenting symptoms he had? That's the first thing. So your history is going to guide you. Okay, and whether this vision became more blurred with time, and because what's the reason why he had a cataract. So they don't get cataracts out of the blue, see. It might be because of treatment, previous treatment, or maybe just because of the inflammation itself. So what does the B scan show as well? Okay, does it show any vitreous opacities? Yeah, so again, what you see on the iris, okay, what you see in the fellow eye. So all that's going to guide you in terms of the treatment. Yeah.
So your provisional diagnosis will be an anterior or a posterior?
You can't make a diagnosis just based on this, unless you have more history. That's why the history is very important in clinical examination.
Sorry, I got one question to ask. When you comment about flare and also cells, for example, flare 1 plus or cells 1 plus, what's the clinical significance in between when we are commenting about this patient cell 1 plus or flare 1 plus?
This is monitoring actually. Flare and cells are very different. Yeah. Flare is like equivalent to tantamount to you looking through, basically when the sun shines, through the window sill. Then you see this basically pale like a smoky view, across. Then you see all the little dust. Okay, so the little dust thing that you see when the sunlight shines across is like a cells. But that haze or the sunlight, the beam that comes through the window is more of a flare. Okay, so that is actually what you're alluding to. So there are two different signs. Yeah. Yes.
Just got one question.
Yes.
When you say sometimes it's there's a spillover, how do you actually differentiate spillover with vitritis, or how exactly do we see clinically in the patient?
Very good question. Basically, therefore, it's important to distinguish where your primary anatomical site is. Okay, so if you know that this patient, symptoms-wise, he sounds like anterior uveitis, just purely anterior uveitis, and you see cells, in an anterior chamber, you can actually tell where the anterior vitreous space or retrolental space is and where your vitreous space is. Yeah, so you notice that your vitreous is actually very clear, you don't see much cells there, but just if you were to focus the light beam just slightly behind the lens, you'll see that there's actually a lot of spillover cells. So it's number one, where the anatomical site is. Okay, therefore clinical history and examination is very important. Okay, and number two, if the patient tells you that they began with seeing floaters, blurring vision, then again that's going to direct you towards something else like an intermediate uveitis. Then you are actually more sure that you're pursuing something in the intermediate or the pars plana area. Okay, so again, history is very important. Yeah.
Can I just ask you, do you use flare cells laser? We don't know. So anyways, to answer your question, flare is an evidence of breakdown of blood aqueous barrier. And anytime you have chronic inflammation for a long time, you will have blood aqueous breakdown. So although some people like flare cell meter, in my center we do it, and I have clinicians who like it. I tend to use it more for. I tend to use it more to document that there is no inflammation. When I want to prove in a case in point that I'm not going to treat this patient and there is no active inflammation, I use that. But it's also useful for research because you've got some papers out there and everything. But on a clinical basis, I don't use it because if there's flare and there's cells, I can see it. So it's a money for the patients that I can already see. So now I'm going to talk about tests and what should I order in the practical approach.